Welcome, everybody. Today, we are really fortunate to hear the talk of our next generation cardiovascular pathologist, Dr. McDonald. So she has two very interesting papers. One related to daily practice, very practical and very important. Second, talking about genetic counseling, really cutting edge. So that's really very interesting. And now please take it over, Michelle.
Okay, let me share my screen.
Well, she is looking at the screen. Michelle is the DO from Texas College of Osteopathic Medicine, and now APCP residency finished at University of Texas Health Science Center, Houston, and now is doing her first year cardiovascular pathology fellowship at University of Texas Health Science Center. And the next fellowship will be autopsy, right?
Right, yes, I'll be doing forensics next, yeah.
Very good.
Okay, you guys can see my presentation?
Yep.
Yes.
Okay, excellent. Right, as he said, I'm Michelle McDonald. I'm happy to be speaking with you guys today. The first paper that I'm going to talk about is this one, cardiac hypertrophy at autopsy. Basically, it goes over how to evaluate hypertrophy in a methodical way. So why is it important to document cardiac hypertrophy? It's very important as it can be a cause of death, and it can also be associated with a lot of familial diseases, and so we have to document it appropriately so that it can be worked up appropriately. So the first thing when we're talking about hypertrophy is we have to decide if it's physiological or pathological, and that's where they start with this article going over the physiologic hypertrophy, which occurs in athletes and during pregnancy, which is eccentric hypertrophy, and distinguishing that from pathologic hypertrophy, which is due to volume and or pressure overload, as well as storage and infiltrative diseases, systemic disorders, and cardiomyopathies. In general, this is going to present with concentric hypertrophy. So how do we evaluate the hypertrophy? We need to assess the cardiac dimensions with a uniform approach so that we can communicate effectively with each other about what hypertrophy is and when to call it. So we need to all have a terminology that we use, a standard methodology to measure the heart, and there needs to be a systematic use of cutoff values. So these are the terminology definitions that they have presented here in this paper. And I think it's pretty straightforward. We're going to come back a little bit to this at the end of this part of the presentation. So here are their recommendations on methodology. First, for the heart weight, I'm sure this is very similar to how everybody does it. Make sure the heart is empty of the postmortem clots. You transect the aorta and pulmonary artery at 1 centimeter above the origin, and make sure there's no attached tissue. They do point out in this article that formalin fixation has no significant bearing between the fresh and the fixed state, and even if it is fixed, it only adds a little bit, and generally it returns to the normal weight after about 3 weeks in formalin. So for the dimensions of the heart, we measure the width and the length. So the transverse size, the width, it's best measured there at the atrioventricular sulcus from the obtuse to the acute margin along the posterior aspect. And the length of the heart is also measured posteriorly between the crux cordis and the apex of the heart. For wall thickness, they suggest cutting the heart into transverse sections starting at the mid-ventricular level and then parallel transverse slices at 1 centimeter intervals to the apex. They do strongly recommend against longitudinal sectioning, as that doesn't give you an adequate view of the thickness. So when you're measuring the individual ventricular wall thicknesses, you measure at the mid portion. So it'll basically be at that first slice that you have made. And you want to measure at the mid portion of the posterior wall of the right and left ventricles and in the middle of the septum. And they do point out you need to exclude trabeculae and the epicardial fat. Here's that diagram of theirs in total. For the remaining base of the heart, they state to open it along the outflow tracts so you can assess the basal structures and the valves. You need to pay special attention to the geometric shape of the left ventricle outflow tract and the presence of endocardial friction lesions. You also need to pay close attention to the aortic valve and the aortic arch, so you can exclude causes of pressure overload there. What about the chamber sizes? So they note that the measurements of the ventricular chamber sizes is proposed to be at the mid-ventricular level, but there's not a clear consensus of this. And the assessment of atrial size is even more unsure. We also have to take into consideration postmortem changes. They note that the postmortem thickness is different from the echo values. It's often more compatible with the systolic values from echo. They note that rigor mortis will lead to increased concentric thickness of the left ventricle wall. In this case, it's artificial and the heart rate will be within normal limits. And decomposition changes like putrefaction can lead to thinning and discoloration of the myocardium with artifactual chamber dilatation. In these instances, the heart rate again is either normal or even diminished. So they recommend routine histology that produces at least 10 sections. So they will have 3 sections from the left ventricle, the septum, and of the right ventricle free wall, as well as the right ventricle outflow tract, as well as any other areas with macroscopic abnormalities. And they suggest routine H&E and a connective tissue stain with other tests as needed. Then in this article, they do a nice review of the different patterns of hypertrophy, beginning with the histology. What is the characteristic histologic changes of hypertrophy? So the definition is going to be when a cardiomyocyte diameter is greater than 15 microns. And this is for the most part associated with nuclear changes, including enlargement, bizarre shapes, irregularity, and hyperchromasia. They have a nice example here of normal versus hypertrophy. In the top, that's a normal perinatal heart, and you can see that there's relative similarity in the thickness of both ventricles. The middle picture is the normal adult heart, and the bottom picture is showing hypertrophy with both thickening of the right and left ventricle, and the histologic correlates are in the column on the right. They have a good table here that shows patterns that you would see in different disease types. And they have some good images as well, correlating to all of the different patterns you could possibly see. So just for a review as they do in the paper, so the pressure overload is going to lead to the symmetric concentric hypertrophy. In this case, there's no cavity dilation. Generally, it's seen with hypertensive heart disease or aortic valve issues, stenosis, etc. Hypertensive heart disease is by far the most common form of left ventricular hypertrophy relating to systemic hypertension due to increased peripheral resistance. And over time, this can eventually sort of transform into kind of a dilated cardiomyopathy gross picture. So on the other hand, there's volume overload, which will lead to eccentric hypertrophy. And the key feature here is the cavity dilation. And this occurs physiologically as described in athletes and pregnancy. Pathologically, it's generally diseases with aortic or mitral valve issues. And it'll lead to severe chamber dilation with a decreased mass volume ratio. These can be acquired or congenital, and it's very important to look at atrial dilatation, in this case, to look for the valve incompetence. So moving on to the primary cardiomyopathies, I think characteristically, these are the ones that are thought about for the primary cardiomyopathies with the asymmetric hypertrophy. They have a nice image here on the left. That's the disproportionate septal thickening. In the middle, it's the asymmetric interlateral thickening. And on the right is a dilated cardiomyopathy. Also, we can think about the left ventricular non-compaction cardiomyopathy, which is kind of an in-between entity. So the primary cardiomyopathies we're talking about are going to be hypertrophic cardiomyopathy. This is the most common type, and it generally is involving genes for sarcomeric proteins. It's really important to remember that there is extreme phenotypic variability. So that classic image we always heard about with the asymmetric thickening of the septum is not always true. There can be concentric thickening, eccentric thickening. It can also be just regional. So it is very important to thoroughly examine all segments of the heart when you're dissecting it to look for even those one or two regions that may be thickened. So the classic histology is going to be the myocyte hypertrophy with the architectural disarray and interstitial fibrosis. The other primary cardiomyopathy is the dilated cardiomyopathy. So this is familial and acquired. So familial causes are more varied than for hypertrophic, and they can involve mutations in numerous different entities in the sarcomere, mitochondrial. There's also neuromuscular disorders, and acquired conditions can cause this. For example, toxin exposure to diabetes, arrhythmia, myocarditis, and pregnancy. In this case, the histology is going to be myocyte hypertrophy with degenerative changes. And you'll also see interstitial fibrosis, and there can be replacement type fibrosis as well. So this is the nice image in their paper showing the disarray in the architecture, as well as the increased interstitial fibrosis. In the bottom right image, there's sort of an area of replacement fibrosis, and that also highlights the small vessel disease. So just a couple notes about hypertrophic cardiomyopathy. We have to remember that myocyte disarray is not pathognomonic. We can see it in other heart diseases, and there are areas of the heart where it is physiologic. So you have to be aware of that when you're taking your sections. Also, it's important to recognize that hypertrophic cardiomyopathy might have a normal heart weight and thickness, but histologically there's widespread myocyte disarray. So you need to think about it even if there's not those gross signs of hypertrophy. Other things they point out is that myocardial bridging is much more frequent. as well as intramural small vessel disease. And you have to remember that all of these cardiomyopathies can have other things superimposed on top, and ischemic myocardial injury is one that's often seen along with hypertrophic cardiomyopathy. We also have to be careful with discriminating from secondary hypertrophy, such as due to hypertension. So discrimination can be difficult sometimes, and in those cases where there's doubt, it's important to go for molecular testing if you can. So moving on to the secondary cardiomyopathies, these are generally presenting with a more diffuse picture. So you're going to get the biventricular symmetric hypertrophy on the left. It's showing the cardiomyocytes with diffuse vacuolization. And then in the middle there as well, and on the right, pardon me, it's the more of an interstitial process we can see with the amorphous material with amyloid. And as you can see in the insets, ancillary testing is really important in the workup of these conditions, electron microscopy and special stains. So these kind of disorders can produce either concentric or eccentric hypertrophy patterns. And as I noted, it's either localized to the interstitium or within the myocardial cells. So you have the storage diseases or something like amyloid. Another thing to focus on is compensatory hypertrophy. So this is what occurs when there's loss of myocardium. Most commonly we see it with ischemia, but it's also important to think about inflammatory or infiltrative processes like myocarditis. You can see it localized in something like mitral valve prolapse or arrhythmogenic cardiomyopathy. Right ventricle hypertrophy. It's also generally a pressure overload driven phenomena, and pulmonary valve issues or pulmonary hypertension, or really bad left-sided heart disease with left heart failure will lead to right ventricle hypertrophy. It'll generally be of the concentric type. Another thing to consider is pseudohypertrophy of the right ventricle when there's epicardial fat merging into the myocardium. This can be seen in obesity, but you should also think about arrhythmogenic cardiomyopathy where the fatty infiltration will also be associated with fibrosis. They go on to describe these other more complex or mixed pathophysiologic subtypes, such as those with diabetes, obesity, congenital heart disease, and particular drugs. As well, we have to remember about idiopathic left ventricular hypertrophy. So it's usually concentric, and there's no disarray at histology, but the myocytes are hypertrophic, and there's no history of hypertension or other explanations. So then there's the whole discussion about the normal ranges as well. I sort of saved this part. They provide a couple of charts in their supplementary tables, which show a lot of data from a lot of different studies giving a bunch of different ranges. And there's always the conversation, which is the best to use. They also have a supplemental table for children and infants. And they, in general, give the definition that a heart weight greater than 400 grams is abnormal in females and greater than 500 grams is abnormal in males. And for wall thickness measurements, anything greater than 1.4 centimeters for the left ventricle, 1.5 for the septum, and 0.5 for the right ventricle. So now here's the time we can have our discussion. One of the comments that I had about this, their terminology definitions. This is basically an issue of semantics, but cardiomegaly versus hypertrophy. In my mind, the way I think about it, when a heart has a increased weight, that's how I think of cardiomegaly, while hypertrophy, I tend to think of it as more of a cellular process. So if you're seeing the hypertrophy of the cells, then you can call it hypertrophy versus something like amyloid, which will increase the weight, but not necessarily cause there to be hypertrophy. So I think there can be a little bit of confusion sometimes in the way they chose to define these, but I'm interested to hear your thoughts on that. Just going over how we measure things. We have distinct processes between the way we handle our explant hearts versus our autopsy hearts. And obviously explant hearts, everything is kind of off because they've frequently, been amputated at the atria. But we will generally do 2 weights for the explant hearts, and we'll weigh them after they've fixed. So we'll weigh them with and without the ventricular device if one is present. Our autopsy hearts are weighed fresh. As far as measurements, we tend to do more measurements for our explant hearts. And some of the hearts at autopsy will measure the left ventricular wall and the anterior, lateral, and posterior, as well as the septum and the right ventricle. The other, at autopsy hearts without gross asymmetry, we'll just do 1 measurement for each. So here are the reference values that we use at our institution for weights and sizes, and these reference ranges are actually not in the chart that they have in their paper. So I thought that was interesting. But I think overall their assessment that more than 400 and 500 grams from males and females, or for females and males respectively, is an okay way of evaluating. Also on sections. So for our explant hearts, we take 10 sections routinely, but they're not the same sections as what they recommend in this paper. So we'll actually take 3 sections of the left ventricle, 1 of the septum, and 1 of the right ventricle from 2 different transverse slices. And for autopsy hearts, we'll generally take 3 sections, left ventricle, septum, and right ventricle, as well as the other areas of macroscopic abnormalities. One thing that I felt was missing from this paper was also a discussion of the conduction system, because that can be part of the evaluation. Looking for hypertrophy can be associated with conduction abnormalities, so it's important to evaluate that. Definitely for all our hearts, we always take the AV node, and for our autopsy hearts, we will take the SA node as well. Generally, we can't do that in the explant hearts because of the atrial amputation. And there we are, no discussion of the conduction system. Okay, so now we can take some time to discuss this first article. I'm interested to hear how things are done at the various places where everyone is.
So, yeah, I'm interested to hear too. So let's see. I think Mark has left, right? Mark is no more here. Yeah. So that's my when I read the paper, I think we're talking about the hypertrophy as a weight. Is that right in this paper?
Mm-hmm.
That's really kind of what I'm a little bit surprised too, because this hypertrophy, to my, I just like you, to my understanding, is a little bit more, proliferation cellular process, and more reflect as dimension. And megaly is also big, right? So so I actually I don't know if Christina have any comment on that, because it comes from European Society of Cardiovascular Pathology.
Yeah, ciao, good evening. And congratulations for the presentation. It's not my paper, it's really a document of the association, so a group of cardiovascular pathology. The focus was to make clear that you should call hypertrophied an heart when there is really hypertrophy, because many misdiagnoses are put forward just because there is a hypercontraction post-mortem, a wrong way to measure, and so on. So I agree with you about the comment of cardiomegaly. Cardiomegaly means that is also enlarged the heart. In hypertrophy is not necessarily enlarged, because you can have eccentric or concentric hypertrophy. So this was the point. I mean, the most important message was really to have normal parameters to judge, and when it's not possible to have a rough way to judge whether it's normal or not normal. If I can, I would like also to make a short comment on your final statement about the conduction system. Conduction system was not part of the paper because it's not part of the hypertrophy. I mean, when we have to judge whether the heart is abnormal or normal in terms of thickness, in terms of weight, is not the conduction system investigation making the difference. It can be an additional, finding, particularly when you have a sarcoid or other things, but by itself, at least in the European side, we really think that the conduction system investigation should not be performed routinely, because it's not, from the forensic viewpoint, really able to provide you a clear-cut diagnosis of the cause of death. Is the exception, is not the rule. So just to have a descriptive findings of fibrosis, of fatty tissue infiltration, besides inflammation and sarcoid, is not enough to really find a solution to the case. So this is why it was not discussed, because it's not part of the diagnosis of hypertrophy. Okay, I hope that to be clear in this. But of course, the other people who wrote with me the document are not here to discuss. But this was the main message of the paper, to really differentiate normal from abnormal.
Right.
Yeah, I totally agree with Christina about this point, that evaluation of gross examination of this nodal abnormality is not so diagnostic, so to say. It is a morphological evidence to support one or another, but it may be not primary. So that is well understood. Also, I have a couple minor points here. I think our growth in paradigm, Michelle, is pretty similar here at Yale, pretty similar with like you, but now, as Christian mentioned, as long as we standardized one method and everybody agree to use that, it is a good approach. So basically, we try to understand the process, what is really happening. So you mentioned the cardiac weight we do before and after fixation is not big change. I think the measurement of thickness doesn't change too much either, right?
Yeah.
So another comment, I think, in the hypertrophy, the real hypertrophy, or cardiac hypertrophy, moderate, severe, usually is kind of focal, right, or multifocal. Anybody comment local difference between different section or some area, or something like that you are aware of?
I'm sorry, what?
because it's cardiac hypertrophy could be focal, right?
Right, yeah, yeah.
Multifocal. Is this somehow, which part is more easy, or where, what etiology together with, something like that. And by eyeball, it's pretty difficult to judge, right?
Yeah.
Anybody try to put a number on that? You don't realize anybody make that effort, right?
Mm-hmm.
So I think that that is some area really kind of the machine learning or something can really do, right? We do scanning the whole thing, and we can compare with this area, if it's a septum, if that is much more severe than the free wall, maybe it's more related hypertrophic or something like that. I think it's time to address this type of question. We have the two now, machine learning compared to our only eyeball, right?
Yeah.
Maybe something I think we can do. Another thing I think pretty different. You mentioned that ischemic cardiomyopathy is more than almost 50%, right? In your daily practice, it's our number daily practice, and a lot of them are dilated cardiomyopathy, basically, right? It's dilated. You have a very good picture, one area, very thin. That's ideal situation, but many times you don't have that. When you see the section, you see the fibrosis, pretty big, satellite in surrounding, and you wonder, it's really primary dilated cardiomyopathy or ischemic. And to make things worse, you look at the coronary artery, all of them occluded, right? So there are some work, I think there we may make some difference in the future using all this machine learning and big picture evaluation of what all these 10 sections, we carefully measure it, quantify them, and compare. Maybe we can get some answer to the questions, which is pretty prominent too, right? Pertinent to our field and the thing.
Yeah, I mean, I think that's a really good point. I think it's also a confounding factor is just skill level between people when they're making the slices. So I think that's something that would have to be considered. For the most part, people are good at doing regular transverse sections, but it can get off, and I think that throws it off sometimes.
So I don't know, in your institution, in our institution, the PA are very eager to learn. So they, like last month, they reached out to me, how do we cut heart, right? I think that's very good opportunity to educate PA, even during their training process, to standardize the process. That is really helpful.
Yeah.
And no, we need new generation like cardiovascular pathology like you, right? They say, this is standard way. Do this way.
Yeah. I spend a lot of time teaching people how to do it. So. Should we move on to the next paper? Sure, yeah. Okay. Come in. Sorry. Okay. Okay, so the second article is this one, lessons learned from testing cardiac channelopathy and cardiomyopathy genes in individuals who died suddenly. 2-year retrospective study in a large medical examiner's office with an in-house molecular genetics laboratory and genetic counseling services. That is a name for an article. All right, so overall, this article was a study that was a review and analysis of 254 cases, which were tested consecutively in the molecular genetics laboratory in the New York City Office of the Chief Medical Examiner from October 2015 to February 2018. They had a multi-gene cardiac panel that was composed of 95 genes associated with cardiac channelopathies and cardiomyopathies. So just jumping into it, their cohort over that time period of 254 individuals was the majority of them were adults, males, and Black or African American in ethnicity. It is somewhat of a unique cohort, as we will discuss a little later on. For the significant autopsy findings of this cohort, the most common was cardiac, and of the cardiac findings, hypertrophy was the most common, which was seen in 111 of the cases. And it was not uncommon for people to have more than one cardiac finding as well. It's also interesting to look on, I guess, not so interesting considering they were looking for genetic causes behind cases they were having trouble with, but the number of undetermined death was fairly significant. So how did they do their data collection? They really looked at the pertinent histories for these patients. So they needed to look at their personal history and their family history. So personal history, they looked for symptoms or clinical evaluations that would indicate abnormal heart function. The list of personal history items is seen there, which was in their supplementary table. It's in the lower table on the left. And about 30% of the decedents ended up having a personal history, including one or more of those items. The remainder had no history, including those, or the history was unknown. For family history, they were looking for sudden death in young, cardiac arrhythmic diseases and cardiomyopathies, etc. The full list again is there, the bottom table on the right. So about 20% of the cases had a family history. And in this case, it was interesting, 64% of the decedents had unknown family history. So overall, the molecular results, they did find variants in 51 out of the 95 genes they analyzed. 27 cases were pathogenic or likely pathogenic variants, and 99 were variants of uncertain significance, and 128 cases were negative. So here's just a breakdown of which genes they did find variants in, and whether they identified a VUS or a pathogenic, likely pathogenic. So the VUS is the blue, and then the orange is the pathogenic. So some of the genes had more than 2 pathogenic variants. Those are listed there on the right. And those are generally associated with a higher number of results on the chart, as well as genes with high number of variants of uncertain significance. And in this context, they said it was greater than 6. So the distribution of the gene alterations were looked at by autopsy findings or cause of death. So notably, the frequency of these variants was high in decedents who were suspected of having a cardiac arrhythmia or cardiomyopathy. So 20% of those cause of death cases did have pathogenic or likely pathogenic variants, while about 50% of those had variants of uncertain significance. Also very interesting, they found that 23 decedents who had hypertensive cardiovascular disease had variants, with 13% with pathologic variants and 30.4 with VUS. Another interesting point was that 20 decedents had the toxicological evidence of substance use, of which 6 had pathogenic variants and 8 had variants of uncertain significance. Those other causes of deaths were not really associated with pathogenic variants, but they did have associations with the VUS. So when they broke the results down by age, it was very interesting that the test yield was lowest among infants, and no pathogenic variants were found among the 65 infants tested. 3 pathogenic variants were seen in children, 2 in young adults, and 22 in adults. So they also looked at the presence of coexisting VUS in the cases of the decedents who had pathogenic variants, and they saw that half of the adult cases had at least one coexisting variant of uncertain significance. As well as they looked at the proportion of cases with 2 VUS, 2 or more VUS, and they noticed that there was a substantial portion of cases in each age group that had more than one. Importantly, they also found 16% in all age groups with novel variants. So they did analysis to see if they could find any predictor variables. An analysis did not find any statistical significance among any of the variables. And they suggested this was due to the limitation of their sample size with the low yield of the pathogenic variants. So a really interesting part of this paper was talking about the genetic counseling of the surviving family members. So, initially, in total for this study, 126 cases fit the criteria for genetic counseling. Of these, 26 were referred from the medical examiners. So the appointments were beginning in September 2016. And if we remember this, that was about a year after this study actually started. So maybe that was a limitation because that's when they got a genetic counselor on staff. And they noted that the referral process from each ME is subjective. So there's no information on the status of families who did not receive genetic counseling. And they did point out that, however, medical examiners do recommend clinical evaluation for any family of a person who dies suddenly. So of the 26 families that were referred for genetic counseling, 26 referrals, and then there's 24 families who were referred were counseled. So 2 of those families canceled or no-showed. So the decedents for these cases, the age range was from 2 days to 67 years. The characteristics of the cases that were referred for counseling did not fit a pattern. They had referrals from each type of case. They had 1 negative result, 1 VUS, and 1 pathogen, 13 VUS and 10 pathogenic. And notably, 9 of these referrals were from cases that featured multiple variants. So this is just a chart showing the results of the genetic testing. So of the 24 families who attended the genetic counseling session, 23 saw follow-up, 1 did not. The reason for that is unknown. So there were 9 pathogenic cases whose families received counseling and are now in follow-up. This included 1 child, 1 young adult, 7 adults. In the VUS cases, of which there were 13, there was 4 infants, 1 child, 3 young adults, and 5 adults. And here's that chart again, just showing the breakdown. So in the discussion, first point to talk about would be yield. So the percentage of positive cases was 10.6 in this study. which they note was markedly lower than other cohorts with yields upwards of 40%. And they talk about how this is probably due to their their wide inclusion criteria, where they were looking at all sudden death cases rather than just a more targeted cohort. And they also noted that there's in research cohorts, there can often be selection bias from families that are actively seeking care or have a significant history for a related disease process. The low yield specifically in infants was interesting. They hypothesized that this is because there are more likely multiple systems that are involved rather than just those related to cardiac issues. So back to the demographics, we noted that they had a 40% Black or African American population, and the reason for this disparity was uncertain, because this percentage is higher, even the demographic breakdown of the city of New York or in general. And so they also noted that those patients seen, they said this could be due to the fact that there are possibly more of these individuals dying sudden death because they receive less care, as there's more barriers to care in minority populations, as well as the fact that the minority populations are not as well represented in research cohorts. However, previous studies have shown that there's no significant enrichment of these pathogenic variants in this population compared to others. So the very interesting points were the 13% of the pathogenic variants identified in those with hypertensive or atherosclerotic cardiovascular disease. So this talks about the chicken and the egg question. Is the hypertension, it can be secondary to cardiomyopathy, and hypertension can also cause primary hypertrophy. So here we get to the chicken and egg question. They point out that finding hypertensive cardiovascular disease may mask or exacerbate underlying cardiac diseases without physical findings at autopsy. And there can be a co-occurrence of hypertension and pathogenic variants that lead to fatal arrhythmias. And these cases would have been missed if they had used more stringent testing criteria. So their ultimate point here is that there needs to be wide testing, and it includes those even if they have a cause of death that might already be stated. This is also highlighted in the discussion talking about those cases associated with substance abuse. It indicates there's a need for more investigation in this area. Possible that certain genetic variants interact with certain drugs in more devastating ways. And it is important to investigate that so that we can better target counseling towards those individuals. So they then have a little bit of discussion talking about NGS technology. And there are the large number of variants of uncertain significance was likely due to using the NGS. And they were also able to see 42 cases with novel variants of uncertain significance, which warrant further study as well. So they talk about using such a big panel, the variants, they only found variants in 51 of the 95 genes. So they just had a very wide panel that had more or less common genes. and the small sample size would not expect to have high frequency of the rare variants. And they note that it's the decedents and surviving families' best interest to test widely. They also point out that they are able to do this because they have adequate resources and workforce, which may be lacking in other places. The most interesting part to me was the low volume of families who received genetic counseling. So they thought maybe this was due to a delay in time between the testing and when they got the results or when the counselor started. And there might be people who just weren't interested in counseling. Also, they didn't have any follow-up to see if the medical examiners, how their genetic counseling was handled individually. So there needs to be better clarification of what happened in that process, and probably highlighting the benefits of receiving genetic counseling from a board-certified genetic counselor. Other limitations, they relied on a lot of family and investigative reports, which have a lot of inherent issues. And there are limitations associated with NGS analysis as well. Okay, I know we're getting close, so I'll wrap it up here. Just wanted to get the overall impressions of others from this article and how they deal with molecular testing at their own institutions.
Any comments about that? So about genetic, it's a very interesting topic. Well, everybody is preparing it. I realize this paper published in 2019, is that correct?
Yeah.
So the study is a pretty, according, relatively old, quote unquote, old for genetic field, is that right?
Yeah, I thought it still had some really good salient points. As far as the turnaround times being an issue and the lack of follow-up.
Right. Yeah, I don't know other institutions here at Yale. There are strong proportion, people try to propose to do this genetic testing. It's not very successful. For I, as a cardiovascular pathology director, I always like that. I say why I failed all this time, right? Why I cannot convince other people to do it. So I compare cardiovascular to the tumor, which do many genetic testing, next generation sequencing. They have this target and they have the compound. So if you have this genetic testing mutation, they know some compound or targeted, which I don't think is exactly the case for our cardiovascular disease. So I don't know if that my conclusion is correct or not. People can comment on that. I think it's lack of treatment is a big drawback for the cardiovascular folks here.
Mm. Yeah, I mean, that makes a lot of sense too.
Yeah.
I have a comment, if I may. Monica De Gasperi from Padua. I work in both in European institution, and I'm also just an observer at Mayo Clinic now. And I'm just wondering, which is the real rationale behind the choice to apply genetic testing in such a wide population. So I'm used to think that you should apply genetic testing in sudden cardiac death cases in which you are sure which is the substrate. So you should first recognize the real substrate and ideally exclude the known cardiac death. So for example, the in this case, the toxic cases. And then when you're sure about the substrate that caused the sudden cardiac death, then you can apply genetic testing to be sure that there is, or to exclude that there is a genetic underpinning for such a disease. So I'm not sure about the real usefulness of having this kind of results, which can be quite confusing sometimes, especially when you have a variant of unknown significance, but also positive genetic test, for example, in cases where the death was attributed to toxic substance. So I don't know really if this is the correct way to apply genetic testing, but of course it depends on the institution. But I think there are also European guidelines, and this paper does not follow the European guidelines. I'm not sure about the US guidelines, but I think that probably they're similar.
So if my understanding correct, in the European guideline, honestly, I don't read that. So it's kind of exclude some cause of death already well known. For example, toxic or ischemic heart disease. And that is kind of excluded from genetic testing. Is that correct? Or
yeah,
okay, that make a lot of sense, especially if ischemic heart disease, like a big population of sudden death too, right? So if you do that,
older people.
Yeah, that's make a lot of sense to me. Yeah, and then if you include that, you may find some genetic change that cause, say, atherosclerosis, may some genetic change cause hypertension, and then you not exactly address the question, what is in this particular genetic change in cardiomyocyte, right? That's one drawback.
Yeah, I think that's an excellent point, that it's very confounding in these cases as to what, how much is it actually responsible for to show up with these and unknown significance especially. But yeah, it would probably be useful if there was maybe some more stringent rules for this. As far as I know, if the clinician orders it, they can get it. So I guess also talking about maybe more from the clinical aspect of a patient who's not deceased, but they're maybe being worked up for a cardiac issue, they'll maybe look a little wider. But yeah, I think that's an excellent point, and I should have thought of it more in that way.
Michelle, just to address this question, is that possible you find out both guideline for European Genetic Counseling Guideline and United States guideline and post it in this in your journal club?
Mm-hmm. Yeah,
that'd be more interesting to many people.
Just to add in my 2 cents, as a medical examiner, I'm Dr. Morris. I'm at University of Michigan. I'm originated at Mayo. So I can see why they might include toxicology cases a little bit. And that's probably more of an ME issue in that we have, so diagnosis of overdose is a little bit of an abstract thing. We have a persistent problem where there's no good literature on tox levels, consistent literature. You can get very wide ranges. And particularly in the current population with a lot of opioid use, we don't have a way to account for tolerance whatsoever. So we just sort of arbitrarily assume you have fentanyl 0.5, that's what killed you, right? Do we really know? In 100% certainty, no. So I could see they may be interested to see if maybe some of these people are dying, like chronic users are dying because they have sort of an underlying cardiac condition that is previously unrecognized. So I could see why, plus there's that smaller theory that sometimes overdoses cause arrhythmias. Even the exact mechanism of how opioids cause overdose is not as defined as we think it is. So I could see why they might do that. In terms of getting testing, I don't know of any, other than New York, because I think they have in-house molecular, if I remember. Do they do it in-house or they still send it off? But most ME offices have no way of getting genetic testing whatsoever. We write a letter to your family and we say, we think you should probably pursue this. Some offices will save a sample and hold it if they request it, sort of thing. But there's no avenue, and that's because people don't like to pay for things for dead people. That's like what it boils down to, the money.
Yeah.
And then even from a clinical standpoint, because I see, on both sides, with explants, very rarely have I seen that they've got any kind of genetic workup. And I'm not sure how the clinicians are deciding who gets tested and who doesn't. There doesn't seem to be any kind of pattern from what I've seen. Most people don't seem to be getting tested at all.
Yeah.
And then every once in a while I'll see something, but very rarely. So I don't think it's very consistent across there as it probably is in Europe, where you have somewhat more socialized healthcare systems and way to fund these things. I think funding is a big issue. And as you pointed out, Dr. Wang, it's kind of like, okay, we're going to run the test and then what? Because I think a lot of their approach is like, well, clinically, they have dilated cardiomyopathy, and that's what I'm going to use to decide to my treatment. Whether they have this gene or not doesn't really change much for their clinical management. If they decompensate enough, they're just going to, get a transplant or something. And whether they have a gene or don't have genes, I'm going to change that. So I can see why it's hard when you're an insurance company system to rationalize it and get the funding. As I feel the same way. Like, why can't I order tests too? And I think up until recently, VT had a free sort of charitable arm, but they recently shut that down. So that's gone.
Yeah. I know the Invitae, they stopped doing it for free. And I think they were saying it's like $200 or $300 for their cardiomyopathy panel now. But it's definitely not easy as like, we have this here and let's just send it down the hall. I know in my exposure, most medical examiner offices don't really send for molecular testing hardly at all, because it's
you just have no way to pay for it.
Yeah.
There's no money. That's the bottom
If you're prepared to pay it, right? You have
yeah,
to
exactly. They're like, it sounds nice, but how am I paying for that? So, yeah. So
very good. Thank you so much. So Michelle, can you follow up with that 2 papers, so if possible?
Yeah.
And then we will post it, and maybe can remind some examiners this is a quote unquote policy. Yeah. Any more comment? If not, thank you so much. Thank you.
Thank you.
Very good discussion.
Yeah, great. Thank you so much, everyone.
Thank you.
Thanks.
Bye.